good afternoon, or depending where you're joining us from, good evening. Welcome to Open Classroom. I'm Janet Gillow, the Director of Professional Development for the Brown School here at Washington University in St. Louis. For those of you joining on the Zoom webinar, you likely know this, but we can't see or hear you. Chat is enabled, and we really do want your questions and comments throughout the presentation. Send a special welcome to people joining us on YouTube. We are live streaming, and we'll be posting this recording later. We're delighted that you're taking advantage of the opportunity to participate. Want to let you know that we're not able to moderate Q&A through YouTube, though. So I'm joined by my dear friend and colleague, Cynthia Williams, who's the Assistant Dean for Community Partnerships here at the Brown School, and also by Sarah Birch, who's our Associate Director for Admissions. And we know we've been chatting with them, some admitted students and some prospective students in the audience. Before we get started, Sarah, do you have a few words you want to say to our prospective students out there?
Thank you, Janet, and just a special welcome to those of you who are prospective Brown School students and thinking about joining us in one of our wonderful master's level programs. As Janet said, I'm Sarah Birch, and I am an Associate Director of Admissions and Recruitment for the Brown School. And I'm really thrilled to welcome everyone to what is now our second Open Classroom of a new series that we launched this year called Curriculum Showcase. And I'd like to thank Janet and the Brown School Professional Development team for partnering with the Office of Admissions to bring the series to prospective students and also to the community. Hopefully, you know what you gain from today is just a little more knowledge about the topic being discussed, and for prospective students, hopefully it kind of gives you a sense of what you can expect in the classroom with one of the renowned faculty members who are being featured. Today's session specifically offers a sample of the type of issues addressed by our epidemiology and biostatistics curriculum in the Master of Public Health program. Finally, just want to invite you all to join us again next week. We'll be featuring more faculty, including Dr. Rodrigo Reyes, who is the co-interim dean of the Brown School, as well as later in the year and semester, Sean Joe, Trish Cole. So lots to look forward to. Thanks again for being here. And Janet, I'll turn it back to you to introduce today's speaker.
Great. Yeah, I'm just going to give people a quick heads up on what's coming up next week. This is our last program of this week. 3 different opportunities to engage with Open Classroom next week. So on Tuesday, we've got an early presentation because our speaker is joining us from India, and that scheduling is challenging. But Dr. Srilatha Juva is going to be speaking to us on inclusive perspectives, making the invisible visible. That's on the 18th of January. Then Wednesday, the 19th, that's that talk with Sean Joe that Sarah was talking about. And that's going to be kicking off our Black History Month event. Cynthia has been amazing leading a team effort. I am blown away. I hope you are blown away with what we have coming up for Black History Month, and this is going to be the first event. So we'd love to have you come join us for that. And then finally, on Thursday of next week, the 20th, that's that event with interim co-dean Rodrigo Reyes that Sarah was mentioning. So I'm going to throw a link in the chat in just a second if you'd like to come back for that or any of the other 40 things that we have coming up. There is a lot to choose from. You are welcome to all of it. But now it's my great pleasure to introduce our speaker for today. Associate Professor Deborah Salvo is the chair of our Epidemiology and Biostats concentration of the Master's of Public Health program. Her research focuses on spatial and place-based factors that influence physical activity and other health-related behaviors with the goal of reducing health disparities and promoting health equity. She's also very interested in leading capacity building efforts for the fields of physical activity and spatial epidemiology in Latin America and other low and middle income settings. So obviously today's talk is right in her wheelhouse and likely similar to a lecture you'd receive if you were sitting in her Brown School MPH class. So here to talk to us about spatial epidemiology for physical activity and health equity research, please welcome Deb Salvo. Deb, take us away.
Thank you so much. Thanks for such a kind introduction. Janet, Cynthia, Sarah, thanks all for having me. So I'm going to share my screen. And if you could just let me know that that's working, then we'll get kicked off with the lecture. And I'll ask Janet's and everyone's help in monitoring the chat, and I'll leave some time for questions at the end. Would be really looking forward to answer those. So first of all, did I share my correct screen? Are you seeing slides?
We're seeing PowerPoint in an editing view.
Yeah.
Yeah.
Okay.
So it just needs to launch the slideshow.
Yes. And let me switch this so you're seeing it properly. Okay. So this should work now. Okay. If anything comes up in terms of technical issues that you're not following my slides, my audio, anything, please let me know. Just interrupt me so that we can correct accordingly. Okay. Well, welcome to today's lecture. Thank you all for joining. As mentioned, this would be a topic that you'd hear me lecture about if you were to join our program, and especially if you were to attend my Health in Place course, which is a transdisciplinary problem-solving course as part of our MPH program, as well as MSW program. It feeds into both. So today's topic is physical activity and spatial epidemiology in physical activity research and a global equity lens. And I'll tell you a little bit about myself and why I have this global equity lens. I am originally from Mexico City, where I grew up in, attended college, and came to the US at age 24 for grad school. And what brought me to the US was essentially the lack of programs and the topic that I was interested in my country, combined with a lot of need. So I was seeing, based on where I was working at, which was the National Institute of Public Health of Mexico, and that's equivalent to our CDC here, type of thing. So we were seeing a big problem with physical inactivity, and we did a study where we estimated the burden of physical inactivity on healthcare systems and on all-cause mortality in Mexico. And it's a big contributor to both of these factors, yet unfortunately, there back in the day, this was back in 2006, so it's been a while, but there were no physical activity experts trained at the PhD level, really trying to come up with solutions to understand what's causing the physical inactivity in Mexico and to help promote physical activity for everyone. We were seeing a lot of physical inactivity, especially among low-income groups, and that was disproportionately affecting their risk of chronic disease. So I'll give you a very, very brief introduction to physical activity epidemiology and then to spatial epidemiology, which is sort of the niche or field with which I approach physical activity research. But you can use spatial epidemiology for all types of public health or social work research, which I find, obviously from my perspective, it's something really interesting and really cool. Hopefully I can convey that today. So first of all, physical activity, as some of you may or may not know, but it's referred to as a health behavior. It's just like talking about healthy eating or unhealthy eating or smoking tobacco or drinking alcohol. It's a behavior. It's something that we as humans do that then can have physiological consequences in our body that can therefore impact our health. We do know that physical activity is related to a series of chronic diseases. And this is something that a lot of people don't know that aren't in the field, is that physical activity is related to your risk of developing, your levels of physical activity are related to your risk of developing several chronic diseases independent of your weight status. So it's not just because physical activity is really good to maintain a healthy weight in combination with a healthy diet, but even if you have a healthy diet and a healthy weight, if you're physically inactive, that may put you at higher risk of developing certain chronic diseases. So physical activity is health behavior that independently from others can contribute either positively or negatively, depending on your levels of physical activity to your overall health risk. And so today I want to briefly introduce a framework, a theoretical framework that really has helped guide my own understanding and a lot of people's understanding of different health behaviors. So those of us that focus on trying to understand how a health behavior influences health and how we can take a public health lens for promoting the healthy version of that health behavior and reducing disparities, this behavioral epidemiology framework has really helped us. This was developed by Dr. Jim Salas in 2006 and has been one of his multiple seminal papers to the field of behavioral science and behavioral epidemiological research. So what he and his colleagues pose with this theoretical framework is that in order to study a health behavior from an epidemiological perspective, and make sure that we're contributing meaningful evidence, not just because it's interesting for science, but that it will lead to helping solve important public health problems and especially reduce health disparities, we should try to follow, we as a field, you know, all the physical activity researchers in the world should try to follow more or less this sort of linear path of 4 steps. The first one is to really establish a link between that, quote unquote, I should have actually put quotation marks there, health behavior and clinical health outcomes. Why should have I put quotation marks there? Because it's sort of a suspected health behavior at that point. The very first question is this really associated to health? It seems like it would be, because let's say, you know, in the topic of physical activity, well, people tend to feel better anecdotally when they're physically active, when their muscles work well, it helps your posture, you have less pain, you sleep better. So anecdotally, you may think, well, this seems to be helping, right? But do we have evidence that that's the case, that that's associated with actual clinical health outcomes, which can be as broad as all-cause mortality? You know, are people that are more physically active less likely to die young than those that are not, all the way to very specific outcomes like your risk of developing diabetes, dementia, certain types of cancers, etc. So that's really important. For instance, back in the day, before the 1950s, it was thought culturally, it was believed that smoking in certain cultures, not everywhere in the world, that smoking tobacco was actually good for your lungs and that it helped clean them. And this was out there. It wasn't in scientific journals, but it was part of the culture until important studies came out, epidemiological studies at first. And by epidemiological, all we mean here is that they use statistics of populations to draw conclusions and to connect A to B, in this case, smoking, to lung cancer, to heart disease, to mortality, those types of things. So we started seeing patterns like, wait, maybe it's not so good. Maybe it's related to this. We started seeing those patterns epidemiologically, again, with the statistics of population health patterns, before we understood the actual biological mechanisms that go on in our body that make all the substances that are included in a cigarette and that may be bad for your health. So that's a really important step one. Don't just call something a health behavior because it seems that it could be good or bad if we're not really sure. So all of this evidence linking to clinical health outcomes is really important as a first step. As a second step, once a suspected health behavior has been confirmed to be a health behavior by step one, then we should go on and identify which factors are associated with the behavior. So it could be that in a certain setting that you're studying, being male versus female seems to be associated with higher levels of physical activity, or socioeconomic status, or educational level, or having access to certain resources, living in certain zip codes. So it's simply describing the variations in levels of the behavior, the good and the bad, by different factors of the population or of the systems in which the population exists in. So that would be step two. Step three would be to use the information gained in step two of like, well, women seem to be accruing less physical activity than men in this setting. We need to do interventions for women, for instance. So using the information of step two to design and test informations that promote the desired health behavior, but don't just promote it for the people and the groups that most need it, that would be identified in step two. And finally, once we have identified a series of effective interventions, those that work, not every intervention that you test is going to work, and that's okay, that's part of science, then we use those to translate them into sustainable programs, sustainable meaning that they can be embedded within an actual system and policy, so that they can help everybody in society, you know, in this case, be physically active and hopefully reduce disparities in terms of those who are having much more opportunities to be physically active versus those that don't. So why am I explaining all this? Well, first of all, if you were to take my course, I would definitely go into this in great detail, but this really helps position, when you have a research question or you're trying to find effective ways to promote a certain health behavior in a population, to understand where the science is. Do we have a lot of knowledge on effective programs and how to translate and disseminate them? Well, maybe not if most of the science is right now in step 2. And then that's okay. So that tells you, what, I need to start contributing to step 3 so that eventually we can get to step 4. So that's been really helpful for our field, but for many other fields that deal with health behaviors. So just running you through these steps, have we established the link between physical activity or physical inactivity, whichever side you want to see, and clinical health outcomes? Yes, we have. we know that physical inactivity, not being sufficiently active, is associated with all-cause mortality, but also with all sorts of very specific health outcomes like obesity, cardiovascular disease, diabetes, several cancers. And nowadays, we also have a lot of evidence for mental health, dementia, Alzheimer's, bone health, all sorts of things. As background, in terms of my field of research, physical inactivity is considered a global pandemic. Now, I used to present this before we were dealing with another global pandemic. So nowadays, people are like, wait, what? You can have a pandemic that's not infectious disease based, and that's not this type of emergency, global emergency that we're dealing with? Yes, we can. And we have several. Not just physical inactivity, but this is an ongoing pandemic, because the definition of a pandemic is that you have either a disease or a risk factor for a disease. So in this case, it would be the risk factor that's occurring at a much higher level than expected in many countries of the world, crossing not just international borders, but also regions of the world, at least in more than one region, thinking of different continents of the world. So globally, most of the countries of the world, all of the countries of the world, have over 20% of their population being physically inactive. The average level of physical inactivity across countries is 25%. So 25%, and this is for adults. For children and adolescents, it's ridiculously high. It's about 80% of children and adolescents across the world aren't getting sufficient levels of physical activity, unfortunately. And we estimate, as a field, this isn't my specific research, that 5.3 million deaths per year are attributable to physical inactivity. This is 9% of all deaths, and sorry, for space, I didn't say, this is of all deaths due to non-communicable diseases, not of all deaths counting infectious disease, but 9% of all deaths due to non-communicable diseases, which nowadays non-communicable diseases globally account for most deaths around the world, more than infectious diseases. Obviously, once you look at it by region of the world and by country, things may rank differently, but it's an important contributor to mortality around the world. Just to place this in perspective, and it's not a matter of competing with risk factors, everything's important, we have to address everything, but this is the equivalent amount of deaths, of estimated deaths due to tobacco use globally per year. About 5 million deaths per year are due to tobacco use. So when I try to convey the importance of addressing physical inactivity, probably to a non-research audience, because a research audience may start questioning my assumptions, et cetera, but just to place things in perspective, would you be okay today if you saw a 12-year-old or a 10-year-old smoking a cigarette next to you? Probably not, right? But we seem to be okay with children spending a disproportionate amount of time sitting in front of TVs, not getting their physical activity, et cetera. And the level of mortality, of global mortality attributable to both health behaviors is similar. Now, is it really the same? What's happening to a child if they're smoking versus if they're sitting? We can get into that debate later, right? It probably isn't, and that's why we need to be careful with these types of examples. But it's something to put things in perspective and to raise the urgency of the physical inactivity pandemic. It's also very, very costly to healthcare systems and to people's lives. We lose a lot of good, healthy years of people due to physical inactivity. So it's not just, if it's not killing you early, it is making you live miserably. That's sort of the bottom line here. And that's not good either. And this, especially this bottom part, bottom bullet point right here, is especially affecting people in low and middle income countries. So I won't go into too many details, but physical activity, my only sort of important message here is that when we talk about physical activity, I'm not just saying people should exercise or do sport. You can get your physical activity through many other ways, and cities or towns can be designed so that you get your physical activity without even noticing, because they're very walkable, they're very bikeable, they have excellent public transit systems, you don't need a car, etc. Social norm can hopefully be modified in such a way that you have a culture that promotes physical activity in many, many ways beyond exercise and sport. Not activity that happens even in your free time and your discretionary time has to be exercise and sport. That's a subset of this. But some people just really like to dance for fun. They're not doing it for exercise or for sport. They're going out to dance with their friends. And in some cultures, that's the way in which a lot of people are getting their activity during their free time. You may want to, teenagers walking around in the mall while talking to each other, gossiping about what's going, etc. It doesn't always have to be planned exercise, planned sport, but it does have to be at an intensity, or if it's walking, which is a valid form of physical activity, at a certain speed that's brisk enough, that's causing your heart rate to go up just a little bit, not to the point that you can't, breathe properly or talk to your neighbor while walking or whatnot, but it needs to get to this level so that it's health enhancing. Light physical activity, which involves anything from moving my hands like this or my head, or a very, leisurely walk, wouldn't get to that level and give you all the health benefits. Now, even this light activity is better than being sedentary, meaning sitting down, laying down while awake. So it's complex. It's not a simple thing. We can promote physical activity through many ways, right? And then, why do I have number 2 here? Well, because I'm moving through that behavioral epidemiological framework that I was talking about. If you guys remember, I don't expect you to have memorized this at this stage, obviously, but step 2 was, once you've established that you're dealing with a health behavior, identify the factors that are associated with having higher or lower levels of that health behavior in a certain community or society or place that you're interested in. So my particular point of interest and focus is the environment. It goes beyond these individual factors of like, are males more active than females or that type of thing, which actually does relate to environments too, I would argue. But I'm really interested in this level. So this is a very simplistic representation of socio-ecological model, which poses that individual level health is influenced by individual level factors, interpersonal factors, meaning the people you interact with in your everyday lives, environmental factors, and policies. So we know that environmental changes have modified lifestyle patterns in a very, very fast way throughout the 20th century, mainly we saw that change occur. We now have high energy intake and lower energy expenditure, which has led to an obesity crisis in many parts of the world, but also to a non-communicable disease crisis. This has been facilitated and sort of highly, I would say, what's the term? I'm thinking in Spanish. Well, like when you blow on a flame and it just like expands. That's what I'm trying to say. It has been combusted, I guess, by very, very fast transitions, societal transitions and health-related transitions. So demographic, epidemiological, nutritional, physical activity transitions. And also by globally scaled phenomena like globalization, rapid urbanization. So all of this has led to very different environments to what our parents and most certainly our grandparents grew up in. And this has affected our health behaviors. So going into the example of physical activity. While we know, and we have a lot of really good interpersonal strategies or interventions, you can look up in the literature if you're keen, if you want to Google Scholar or go into PubMed, which are databases where you can find peer-reviewed articles. There's a lot of effective interventions to increase levels of physical activity in different types of population groups, etc. But although they're effective, meaning they worked, there's some problems with them. And the people that have developed and tested them acknowledge these problems. First of all, their effect size, meaning how much more physical activity did you get relative to the people that didn't participate in the intervention, are low to moderate. They are still meaningful. They're still statistically significant, which is something that you'd learn about if you were to join our program, what that means. However, apart from being, just a little shift in the right direction, the bigger problems is that there's low maintenance. People that leave that research setting where they got this program that helped them acquire a healthy habit over a few weeks or months of their lives, once that goes away, that structure, that formal research structure goes away, the maintenance of the behavior in people's everyday lives becomes low. Inherently, because most of these programs are based on sort of group-based interventions, exercise classes, these types of things, walking groups, coverage is low. Unless they become embedded into bigger systems like public health systems, insurance-based systems where you could be referred to these types of groups and it becomes part of the healthcare system. For instance, Australia does have this, so their coverage is larger, but here in the US, coverage is pretty low. And in many parts of the world right now, the potential for coverage without systems change is low. And therefore, this currently, as they stand, although effective and really nice programs and a success from the research perspective, they have very low potential for scalability. On the other hand, since the early 2000s, we as a field have been thinking about environmental strategies to promote physical activity. Why? Because even though this seems like a fairly basic phrase, it changed everything. It changed our way of thinking. Jim Salas said this in one of his seminal papers. Physical activity occurs in specific spaces and places. So we should be studying the characteristics of these places and what are the places that are conducive to physical activity through all ways, not just to exercise and sport, but to people walking for transport, biking for transport, other types of leisurely activity, and which are the places and the characteristics of places that are not conducive to healthy lifestyles. So this leads to my other sort of line of thought. I try to merge both physical activity and physical activity epidemiology and spatial epidemiology into one cohesive self, at least in my brain. That's how I operate. I wear both hats of a physical activity and spatial epidemiologist. So spatial epidemiology is a sub sort of type a type of epidemiological research that you can do, which deals with describing and analyzing geographic data with respect to the demographic, environmental, behavioral, socioeconomic, genetic, and infectious risk factors that compose it. So the key thing here is that we're dealing with geographically indexed data. That means that we study everything with respect to how it's distributed in space and place. And it considers both the influence of both of these factors, space and place, on health outcomes. Now, maybe by now people are, I hope not, but maybe some of you are confused as like, well, space and place, isn't that the same thing? So let me clarify. What's the difference between space and place? They're not exactly the same thing, but they're highly interrelated, and both of them matter when studying them with respect to the occurrence of health-related outcomes. Space simply refers to geographic location, to a coordinate. Where am I? If you were to see an empty map that doesn't even have the border of the county or the country or anything that you're in, it's just a set of coordinates. Where is Deborah Salvo located right now? Where's Janet Gillow? Where's Sarah Birch, etc.? That's spatial information. Spatial information is also what's my location relative to somebody else's. So the distance between but it doesn't provide any context whatsoever of whether my location is my home, it's a university campus, it's a park, it's the street, it's a dumpster, it's whatever, the middle of the ocean. It's purely objective locational data without all that context. All of that context, is it a park? Are there people there? What's the culture there? What are the policies there? What's the safety? That's place. So obviously space and place are related. Both of them have influences on health, usually together, but also independently. You can imagine that me being stuck here at home in my sort of made up home office for the pandemic is not very conducive to physical activity. While if my coordinates right now corresponded to a neighborhood park, just inherently by the location that I'm in, I'd be much more likely to be exerting energy, even if it's just walking around the park or something, than I am if I'm in my home office. So that would be sort of the influence of place. What about the influence of space? How would my geographic coordinates alone or in relation to someone else's be related to my health? Let's not think of physical activity right now, but just my health. This is a question that sometimes when I ask it in class and I have, students raising their hand, I actually don't get a lot of students raise their hands. They just look at me all confused, like, well, I have no idea what you're talking about. So obviously I give them an answer. Right now, though, given everything that we're going through, I think it's much more obvious. If I'm sitting here and I were to tell you that I have COVID, I don't, but if I were to tell you, would you want to be at a 3-foot distance from me or 2-foot distance or what? Probably not, right? Because your health risk would be directly influenced by my geographic location, irrespective of whether we're sitting in my office or in my living room, et cetera. Maybe place would start interacting if we were in an open space, right? Or if your geographic location is right next to me, we're like 3 meters away. Sorry, I think in metrics, so I have issues giving examples. But if we're 3 meters away, which is really close, it's about 3 yards or 4 yards, maybe you'd be more comfortable if, yes, we're showing that in a map, we're located really close to each other, but we happen to be in different rooms in a house. There's a wall between us. We're not even seeing each other. Or there's a transparent screen, right? That changes things. That screen or that wall, that's a place-based factor. That's not our location, right? So usually they interact with each other. Okay. So in terms of what else Spatial Epi does, it really tries to integrate spatial thinking into public health research and practice. So it gives us this geographic perspective of always asking the where question, the where people are, the where disease is occurring, the where certain characteristics of a space exist or don't exist as a central aspect of research. But that's not just it. You have to combine it with some content knowledge, which in my case would be everything I know about physical activity epidemiology. But it could be about obesity research, it could be about influenza, it could be about whatever it is that you're interested in, mental health, et cetera, with, of course, some skills that a good spatial epidemiologist should have, like using geographic information systems, mapping, certain statistical techniques, et cetera, which you would learn in my course if you were to enroll. I'm going to skip through this one because I want to get into the global side of my work now. So I will talk to you a little bit about what's going on in the context where I do a lot of my research. It's not to say it's the only place that's interesting to study, but I want to do this as an example of how you can blend physical activity epidemiology research with spatial epidemiology research with global work, which is really what I do. If I were to define myself, those are sort of my 3 major themes, and I bring them together. So most of my work takes place in Latin America, not just in Mexico where I'm from, where I do have a lot of research, but I also work with colleagues mainly in Brazil and Colombia. Some work in Chile, some work in Ecuador, and a little bit in Central America too, but mainly those settings. So why Latin America? It's not just because I'm from Latin America and I've seen the need there, but in terms of physical inactivity, the Americas as a whole, so this would include the US and Canada, not just Latin America, but as a whole compared to all other global regions, so red is bad here, essentially, and blue is good, is the most inactive region in the world. And yes, the US is a big contributor, but you can see South America having a lot of red. And then we have a lot of countries that don't even collect data, that don't even consider it like an important thing to include in their public health surveillance systems yet, which is a problem. So it's a region with a lot of need, with a lot of physical inactivity. globally, 1 in 4 people are considered to be physically inactive, while in Latin America, 1 in 3 people are inactive. So it's significantly larger, the problem. Now, a little bit about our context. What am I talking about here? These are all the place-based factors that a spatial epidemiology just sort of thinks about. All of these contextual factors. I don't know if you guys knew this, but Latin America is the most urbanized region in the world, where where most people live in cities versus rural settings. About over 80%, sorry, of Latin Americans live in cities. It has undergone very, very rapid, over the matter of 2 to 3 decades. It has transitioned in terms of its demographics and epidemiological problems. It used to be a region highly burdened by undernutrition, by infectious diseases, and now the leading causes of mortality in the majority of countries are non-communicable diseases. However, infectious diseases haven't fully gone away. They are still affecting the poorest segments of societies. So it's a region that is dealing with what we call the double burden of disease. Because of this rapid transition, in a matter of a decade or two in most countries, they went from having infectious diseases being their leading causes of mortality, and in a decade or two, it was other diseases. It sort of caught us unprepared. We had a lot of really good experts, top global leading experts in studying things like undernutritious and infectious diseases, with way less people focused and highly trained in studying chronic diseases. And it makes sense because the need wasn't there, especially from a public health perspective. I'm not saying we don't have good cardiologists to attend you in a hospital in Mexico City, et cetera, we do. But in terms of public health researchers and experts and practitioners, we didn't have a lot of people focused on the other side of the spectrum and in health behaviors that lead to obesity or to physical inactivity or those types of things. Therefore, this has led to physical inactivity still today not being sort of fully recognized in most countries as an independent and important risk factor. And so that there's a lot of research capacity and knowledge capacity lacking in the region. Now, what I do want to talk about, is this last point. It's not just that we don't have a lot of researchers doing this work in the region. Because we have very little researchers, most of what we know, again, if you go into Google Scholar or PubMed to find out, hopefully I've made you a little bit interested in physical activity as a field of study. You may want to go and see, what's happening in the physical activity research world. 99% of studies that you'll find out there will come from the US, from Canada, from Europe, from Australia, but not from low and middle income settings. A little bit from Latin America now that we're starting to build capacity, but not a lot. So what does this mean? All the evidence we have, the way of thinking, the research questions asked are highly relevant for high income countries, but not really for low and middle income countries, including Latin American settings. So as a result of most of the capacity being from high income countries, even things, not just the results are not relevant, but even the questions asked are not relevant. So that's something really important to keep in mind. Study conclusions and broad messages that you see from physical activity research in high-income countries are also the result of this sort of framework based in high-income countries. We see this type of phrase a lot, not just for physical activity, for healthy eating, for smoking, of making the healthy choice the easy choice. I'm underlying choice. The word choice assumes that you still have the choice, right? Even if it's hard, maybe your environment doesn't make it easy. But if you really wanted to, you could make that choice. This led me and others to question, is being physically active always a choice? This is a setting in Mexico, right, where I've been doing research for over a decade now. These are neighborhoods in cities in Mexico. This is not rural. These are the outskirts of cities. And we put accelerometers, which are devices to measure physical activity on people. And people from these types of neighborhoods are getting a ton of physical activity. Should that lead me to conclude that they're making a healthy choice? Well, the only way in and out of your neighborhood is through these paths. And by the way, on the other side of this fence or whatever you call it, is a very, very rich area, so that the level of inequalities are also crazy. I have been a very vocal person in saying, you know, not all physical activity is good for you. This is not good quality of life. If it comes at the cost of underdevelopment, of undignified conditions, of stress, of commutes that take 4 hours and walking out of here and taking 8 buses or something to get to your job, it's not okay. So I like to study, how do we promote truly healthy physical activity in settings like this? All I'll say about this one is most people, this is hard to understand for us in the US, but most people in low and middle income settings can't afford a car. So when you see that, oh, it's great, they're using active travel, you know, to walk 40 minutes to get to their nearest bus stop, that wasn't their choice. That's due to their living conditions. They can't afford a car. Most trips in cities in Latin America are not by car. Here in the US, only about the bottom 5 to 10% members of society in some cities, and in many cities, the bottom 1% can't afford a car. That has to do with a lot of different factors that we could get into later one-on-one if you want to ask me, but there's high subsidies for the automotive industry, and there's higher income here, even in the low income deciles. So here I'd like to talk about equity, but in a way that we don't usually think about equity. Equity isn't just redistributing resources, like making hospitals free for everyone, which is something I believe should happen everywhere. But it's also studying the things that matter in the places where it's needed. I really do believe that we need to produce evidence that is relevant to the people that need it the most. It's great that we know so much about what causes physical inactivity in the US and Australia and Europe. This is where all the studies are coming from. But so this map, and this is a technique, building maps like this, that you would also learn if you were to take my health and place course here. So this map is sort of deformed based on the number of people that live in each country. So you can see that the people of the world mostly live in the developing world, in low and middle income countries. Where are we studying physical activity in all the 4 steps of that behavioral epidemiological framework? Where's our evidence from? It's not from where we need it the most. It's not where the biggest problem is. So my research and a lot of other people's research is trying to address this sort of very slim Latin America, basically inexistent Africa, which is a huge problem, etc. Okay, I will just say this, you know, if you find a study, a seminal study in our field, in the field of physical activity research, looked at at what could determine at the urban design level if people are physically active or not, especially for transportation, that people walk to get to places. And somebody came up with what we call the Walkability Index, which you guys probably have heard about, the Walkability Index, Walk Score, realtors use it to sell houses, etc. That was developed in settings like this, where you have the suburbs look sort of like this, and we're trying to say, well, higher density, higher land use mix, access to a ton of different destinations, restaurants, shops, etc. in the same area, and good street connectivity, which means a road pattern that's a grid versus tons of cul-de-sacs. If you get those 3 things combined in an area, we're going to call it highly walkable. And that index, that formula, is statistically associated to more walking in US cities. If we apply that formula to a place like Mexico City, these are the suburbs of Mexico City. Look how dense it is. I can tell you it's mixed in terms of land use. There's a little corner store pretty much in every block, and different types of shops and restaurants and street food, etc. Highly connected. This is a grid pattern. Very, very dense, denser than, the low density areas in Mexico City are denser than the high density areas in most US cities, without excluding New York City, maybe. So if you apply that formula to Mexico, one of my studies found the following. Here, I'll show you this one. we found this sign is a minus sign. That's what it means. I was trying to show plus and minus signs, and the X's means no association. I found that the US Walkability Index was negatively associated to physical activity. This is a measure of physical activity. What does this mean in simple terms? That we were dealing with the anti-walkability index. You know, it's almost like if you reduce what in the US is called walkability, maybe you'll get more walking. But people that live in areas that, according to that formula, would be categorized as highly walkable in Mexico actually had lower activity levels than the people that lived in the quote unquote low walkability areas. So it's a bad label for that formula in Mexico. Without getting into the technical details, the bottom line is context matters. We can't just take findings from high-income countries and translate them into policies and programs in low-income countries. In this case, a policy and program would be recommendations to overly densified neighborhoods that are already really dense, to add more land use mix, et cetera. That leads to literal congestion, not just road traffic congestion with cars. People are walking side to side to each other. You can see how it's not a good place to be physically active given the level of density. We have replicated these types of results in places like Hong Kong, like Bogota in Colombia, and other parts of the world, especially low and middle income countries. And so what we've seen in a study that involved 12 countries is that, yes, in the high income countries where most cities have low densities of people in neighborhoods, you see a very nice linear relation where here in the bottom, you know, the more that you increase these variables that are part of the walkability index, you know, in this case, the higher the residential density, the higher the physical activity. But there's an inflection point where the relation becomes the opposite. And most of the developing world falls here. So again, without getting too much into the spatial epi details of what the statistics means, it just tells us that we can't just study things in one setting and try to solve problems in another one. We pretty much have to reinvent the wheel for different contexts. And I've been sort of pushing maybe for a redefinition of walkability by local context. Different things would compose this walkability recipe in different settings of the world. And I would even say it's relevant for places in the US, you know, for neighborhoods where a lot of immigrants live, where minorities live, that have a different composition, both in terms of literally their physical structure, but most certainly the culture that exists there, the social ties, the social capital, social cohesion, social norm, which are elements that are very understudied, I would say, everywhere in the world, not just in low and middle income settings. So steps 3 and 4 are still pretty much lacking in our field of understanding how urban design and the ways in which environments in which people live influence health. We've done quite a bit of work in steps 1 and 2, but now we need to not just say like, well, the way that our cities are designed are bad for health, for physical activity. How do we change them? How do we make them healthier? We shouldn't just be okay with like, well, the city is the way it is. We built it, we people built it. So sometimes we forget like, yes, that's a modifiable risk factor. Maybe not in 2 years, but in a decade or two. For instance, the city of Paris in 1 decade went from being a very hostile city for bicyclists to being one of the cycling capitals of the world because there's the investment and the capital will that's gone into that. So the next way to go are what we call natural experiments to assess the role of urban transformations on physical activity. And this is a very exciting field of research. I'm showing bicycles here because we have an ongoing natural experiment happening in Mexico City that I'm an investigator on, looking at the widespread scale up of public bicycle sharing programs. Public means this is funded by the city, but by the public transit system of the city. Just making bicycles available to all as part of the public transit system. You use the same card that you used to get on a bus, and it's been such a success. And it obviously helps with things like sustainability and congestion and carbon emissions, but it also helps health. You're building physical activity into people's lives that wasn't there, that was 2 or 3 bus rides before. So I'll just leave you with this image. about context and place mattering. And I'm happy to answer questions over the next 10 minutes or so that we have left.
Perfect.
Oh,
Deborah,
sharing
thank
my
you so
screen.
much. Mission definitely accomplished as far as getting us all more interested in physical activity and how place and space has to do with that. Some good questions already from the audience. I'm going to kind of cheat by giving you two, but one of them is kind of a housekeeping thing. Prospective student Othello is very interested in having a copy of your slides. Do you mind if I provide a PDF?
Oh, absolutely. No problem.
Okay, fantastic. So there is a resources tab on Open Classroom, and I'll post this as a PDF. So if you want to study something in more detail, just go back to the Open Classroom site and that will be available. So we had some questions, including one from Micah, I hope I'm saying that correctly, related to definitions, right? Definitions of activity and inactivity. You gave us some pretty sobering statistics about death and inactivity. Micah's question specifically got to globally, that beautiful map. How are we defining what is activity and where did the data come from? And then I'm like selfishly going, am I moving enough? What is that inactivity?
Yeah, thank you. Thank you. Really important question. How do we measure this? You're already thinking like an epidemiologist, Micah, so that's good. Physical inactivity is defined as not meeting the age-specific guidelines for physical activity for health. So WHO has guidelines for adults, and those are that we need to accrue a minimum of 150 minutes of moderate to vigorous physical activity over a 1 week period. Every week, we have to accrue a minimum of 150 minutes of moderate to vigorous intensity physical activity. And you can think of the moderate intensity, which is the bottom end, as something that raises your heart rate just a little bit or makes you breathe a little bit faster than usual, but you can still hold a conversation. While vigorous activity is the one that is raising your heart rate and how you're breathing so much that you can't hold a conversation while running a sprint or whatever it is. But 150 minutes for adults. For children and adolescents, it's much more. And that's why we have like such high prevalence of physical inactivity, which is the not getting to that minimum level. For children and adolescents, they need to accrue 60 minutes of moderate to vigorous physical activity per day, 1 hour per day. So, you know, technically, if we had good recess with facilitated activities at school, not just like do whatever you want and sit down there, but like actual, you know, activity stations that children can play in and choose, if we had PE often, if parents at home had the time and the space and the resources to play with their kids a bit, an hour shouldn't be that bad because you can break it up as much as needed. 5 minutes here, 8 minutes there, it doesn't really matter. But yeah, that's where we're getting it from. So, you know, if you were someone that an adult that is doing 149 minutes per week, obviously we do know that that's better than those that are doing 0. You're not as bad. It's not like that binary, but we do know that the benefits for your health really start at 150 minutes plus, and you would be categorized as inactive if you're at 149 for these statistics. Now, where do the data come from? I invite everybody to take a look at a project that I and multiple colleagues of the world are a part of, which is called the Global Observatory for Physical Activity. It's a website, and you can see surveillance data from representative samples like NHANES. In the US, it comes from NHANES, which is a national health survey of health behaviors, including nutrition, physical activity, and others. And it's conducted yearly in the US and other countries. They have surveillance systems every 2 years, 5 years, 10 years, depending. Some countries don't include physical activity surveillance in their public health data. So that's where the data are coming from.
Thanks, Deborah. I have to piggyback off of Janet and just say that this is such a captivating conversation and has me interested too. So thank you so much for being here. There's another question, lots of good questions actually coming in. So thank you all for posting these. One from Dr. Deidre, who asked about the public health surveillance that you referenced, and wondering if surveilling is achieved through things like health apps or step counters that people have on their cell phones.
Not yet. That's the dream. There is research that's going on using data, sort of crowdsourcing data from mobile devices from across the world, and some really interesting studies that have gone on. Right now, we as epidemiologists are a bit worried about bias, about sort of selection bias. Hopefully, I don't know if this term is, if everybody here is familiar with the term, but essentially, when you use smartphone data to determine if populations are being active, in certain parts of the world, everybody has access to these devices, in other parts, not yet. So you may only be getting people of a certain socioeconomic status, and you're not really capturing the whole spectrum. But there is some work around that. We still have a lot of sort of technical and measurement challenges with making sense of those data. So currently, surveillance data is mainly based on self-report. There's a few countries of the world that are using accelerometers, which are not like based on cell phones. They're based on actual devices that get mailed to people and they wear for a week. They're like pedometers, but better. They measure the intensity of the activity, not just the steps. And that's mainly where we're getting it from. But for the most part, it's self-report. So we do know that there's more error there, but also a really, really important thing to keep in mind with that is the 150-minute guideline comes from epidemiological evidence based on self-report. So whatever that means for an accelerometer, and the accelerometer may measure those self-reported 150 minutes as, I don't know, you did 70 minutes. It's fine. It probably means that the accelerometer-based guideline, if we ever get to that, would be 70 minutes. So it's fine that it's whatever you are perceived, you think you got when you remember and you add things up.
Great. We have a question from Danielle. It again gets to these guidelines, and she's specifically wondering if there are any modified guidelines for folks when there is a physical activity limitation. My hunch is she's talking about physical disability. Yeah, I'm looking for resources on that.
Yeah, so WHO in 2020 published a new version of their guidelines. And they do have a whole section on people with disabilities. Right now, essentially, the evidence is limited. So what is being recommended based on the evidence that we do have is still the 150 minutes, but what we do have to, there's sort of some phrases or some caveats there in saying, do physical activity to the level that you can, to the level that your health provider says it's safe. And moderate intensity activity will mean something different to some folks than to others, and thinking even without disabilities, older adults, there's specific guidelines for older adults. What raises your heartbeat as an older adult may be what for a younger adult may fall under light intensity activity. And that's okay. What you really want to look for is what is raising your heartbeat in a way that you still feel safe, that you're not pushing too much. And we do have a lot of evidence that you don't need to do the vigorous activity if you don't want to. You can get everything you need with the moderate intensity activity. So, if you're in a wheelchair, just, don't use the electric one, you use a real one, at least for part of the day, and try to get to that minimum. What we also say in terms of the guidelines for people with disabilities or certain health conditions is, if you can't get to the minimum, do as much as you can. Some is better than none. We do know that, getting halfway through is much better than zero. Yeah.
Right. One more question before we wrap up today, and this is a good one, I think, to end on. Dr. Deidre Thomas Murray asked again a really good one. Walking, outdoor activities, and just being physical was kind of hijacked by things like federal policies, budget cuts to end PE in schools, video crash, PlayStations, Nintendo, and the pandemic didn't help either. So how do we reverse the inactivity pandemic?
Oh, wow. That's the jackpot question. Thank you, Dr. Deidre. your question or your comment is the motivation of my research. You are describing all the place-based factors that have made it difficult, that have like engineered physical activity out of our daily living over centuries, some of it with technological developments for transport, for occupation, for leisure too. You know, before kids didn't have the distraction of Netflix, of video games, or whatever, they wanted to entertain themselves. They had to somehow be more physically active, at least part of the day. So both sort of over centuries, but then there's also some specific crises like COVID, stay-at-home orders, etc. How I wish I knew the answer to this. I'd be out of a job probably, but I do know sort of a very generic, probably not very satisfactory answer in the, oh, well, how do we do that? But it's, we need to think of systems. If we keep giving the message and the responsibility, sort of the burden on the individual, it's just not going to work. I mean, everybody knows that physical, or a lot of people know that physical activity is good for you. Hopefully today, you know how good it is and how important it is. But, you know, Dr. Jim Salvo, which I referenced a lot during my talk because he's been sort of a guru of these things. Look up his work, it's great. He always uses an example. Like, you know, if you teach somebody to swim and become the best swimmer in the world, the Michael Phelps or whomever the best swimmer is nowadays, that's great. You know, you can teach someone to really improve their motivation to lead a physically active lifestyle. If you threw Michael Phelps in the Niagara Falls, you would still drown, even if it's Michael Phelps, right? And that's what we're doing. You know, we are putting, especially in the US, which is a very individualistic system, society, and it has to do with politics, economics, the history of the country in itself, you know, how we were born out of like individual freedom and the right to own land and a lot of different things that go against public health, which is more community-based. But we throw them out in a system that's not going to help them. So I think we need to work with the systems. Public health is not about hospitals and clinics. It's about everything else. You know, so that's all I'll say.
That is actually, I think, a beautiful place to leave us. Some wise words. This has been such a pleasure. Dr. Salvo, thank you for delivering this lecture, giving us a peek into what it would be to sit in on one of your classes. I'm now wishing I had that opportunity. I want to thank Sarah for jumping in as co-host, and to the audience for really thoughtful questions. It's been a pleasure to spend this time with you all. And we are at time, so we're going to close out this webinar, wishing you all a very healthy, safe, and active rest of your day. Hoping to see you again at another open classroom very soon. Please take care, everybody. Goodbye now.
Thank you all. Bye.
Everyone.